if they feel like they're well for 3 months,
Mm-hmm.
they have no symptoms, and they wonder why they've been taking this medication for 3 months, then I think it's a reasonable time to stop and see what happens.
So maybe at this point you can give us an overview of what your typical approach to treatment is for chronic UTI.
Well, the most important when I evaluate someone is their history.
Mm-hmm.
I'm going to ask them some general questions. I want to know about their frequency, their urgency, how many times they get up at night.
Mm-hmm.
I want to know if they have pain in their lower abdomen, if they have pain in their urethra. The physical examination of patients with this problem is not helpful in general.
Okay.
I mean, typically they're going to have tenderness in the lower abdomen when you examine. They're going to have tenderness in their bladder, and they may or may not have tenderness in the urethra.
Mm-hmm. Yeah,
So
that makes a lot of sense.
history is very important in the diagnosis, but it's even more important when you follow them up to monitor treatment, to see if you're having any impact on their disease.
And when you
ask
say
them the same question over and over and over every time I see them.
Mm-hmm. When you say treatment, in your case, does that mean a long-term full dose antibiotic generally?
Yes.
Okay.
Yes.
And do you also prescribe methenamine hippurate or Hiprex alongside that?
I do not. I have used Hiprex for patients that are completing treatment
Mm-hmm.
in hopes to prevent recurrence, so that the problem doesn't develop again.
Mm-hmm.
Once somebody's had this problem and they get well, they look at you when you tell them to stop their antibiotics like you've lost your mind, because they under no circumstances do they want to go back to that life that they had.
That's understandable.
And many patients, I have so many patients that I followed for years and years and years, 10, 15 years, they will not stop their medication.
Even after that amount of time?
Absolutely.
So
yes.
How do you decide when someone should try stopping treatment? Is it based on symptoms or testing?
Yes. I'm interested in how they're, if they feel like they're well for 3 months,
Mm-hmm.
they have no symptoms, and they wonder why they've been taking this medication for 3 months, then I think it's a reasonable time to stop and see what happens. It certainly
Mm-hmm.
doesn't guarantee that, it's going to be successful. Because many patients have, deeply embedded infections, and it's almost unheard of for me to stop somebody in under a year.
Yeah, I was going to ask what the typical length of treatment is. Do you think the average is a year, or is it longer for a lot of people?
It's pretty much a minimum of a year.
Okay. And do you think the duration of treatment is related to how long they've had the problem, or is it related to other things? Okay.
I do.
But it is possible to overcome this even for people who have suffered for a number of years?
Oh, yeah.
What do you think the success rate is for this kind of treatment?
It's very much related to patients' age.
Okay.
The younger patients are, the shorter the time span they've had it, the higher the success rate. The older patients are, the longer they've had it, the lower the success rate is.
Okay.
And there's obviously outliers on each end.
Mm-hmm.
I'm a clinician. I don't have time, energy, or desire to do research.
Mm-hmm.
So I have to, make decisions based on my experience in the clinic. I'm resource limited, with help.
Mm-hmm.
So you just have to budget your time, and my time is best spent treating patients.
Yeah, sure. If someone doesn't appear to be getting better on the protocol, what action do you take then?
Well, if I have a patient that is not responding after 3 months of treatment,
Hmm.
I'm going to make a change,
Okay. Is that
without
usually
question.
a change in the antibiotic or something
Yeah.
else?
I may even repeat their microgen.
Hmm. Yeah. How often do you recommend retesting? Is there a certain time frame?
Yeah, I really don't. I'm more interested in, again, I'm more interested in symptoms.
Hmm.
If their symptoms are improving with treatment, in my opinion, there's no reason to do testing,
Hmm.
because no matter what I saw, I'm not going to change their treatment because they're getting better.
Okay.
Now, when if somebody was doing really well for several months on treatment, and they went, say they went a month and just a tailspin backwards,
Hmm.
that would be, in my opinion, an indication to test again and see what's going on, and see if something else is showing up that's resistant.
Okay. How long do you think it's safe to take antibiotics at that kind of dose? You said some people are still on those doses 10 or 15 years later. Is that a recommended, or are there concerns around that?
Well, I think that you know your risk of the your risk of treatment is essentially resistance, or
Hmm.
complication from the medication, C. diff,
Hmm.
uh, musculoskeletal injury, or something like that. Um, I continue to be amazed at how well people tolerate antibiotics in general.
Hmm.
There's a lot of boogeyman um, talk about antibiotics, antibiotic resistance, and I think people are more likely to develop antibiotic resistance when you treat somebody with a short course of antibiotics that fails.
Hmm.
Dead bacteria don't develop resistance.
Right.
It's the strains that are incompletely treated that develop antibiotic resistance.
Do you think the long-term use of antibiotics has an impact on gut health and potentially immunity in the long run?
Well, I think that there's no question it's gonna affect the flora in the gut, without
Hmm.
question. Some of them are better or worse than others. I mean, like macrobid's not going to have much effect, in the gut.
Hmm.
Uh, Things like Bactrim and Augmentin, while it's one of my favorites, I mean, it's the triple whammy. It gets gram negatives, gram positives, anaerobes. I mean, it's a major it's a major insult
Hmm.
uh, to the body, but nevertheless, people can end up tolerating it very well for long periods of time.
Yeah. Do you recommend anything to support that? Do you use probiotics or other gut
Uh,
health supplements?
I do suggest patients use a probiotic,
Hmm.
and I don't have a preferred one. I just suggest they get whatever's cheapest and whatever they tolerate the best.
Okay. You briefly mentioned C. diff. Do you see a lot of instances of that in your patients?
We see it occasionally. Now that I'm seeing more and more patients that are more and more complicated, I
Hmm.
think I'm seeing it a little bit more. But I still am amazed at the at the small numbers of that we really see. I mean, it happens, and it's a risk, and the patients are all informed of it.
Hmm.
And when they have symptoms, they know that they're to go to, get a C. diff test.
What happens for those patients that can't tolerate antibiotics or have had a C. diff problem? Is there a different approach they take?
Well, I've had a few, very few, that the way this treatment works is because the antibiotics are ingested, it goes into the bloodstream, it's excreted by the kidneys, and the urine becomes a bath of antibiotics,
Hmm.
right? So the antibiotics is in the urine at all times.
Hmm.
So really, the only way to replicate that uh, with any other treatment than systemic antibiotics is uh, some type of infusion into the urinary tract,
Hmm.
which is very difficult, or instilling after every void, so that they maintain
Hmm.
contact. That's quite a commitment for people to make. But when you're faced with no other options, you know, that will work. Now, I think an intermittent installation is going to fail. You know,
Okay.
a weekly installation, a daily installation, because you still have that long period of time where there's no antibiotics in their urine.
Yeah.
The bacteria the bacteria can escape into the urine, replicate, and just reinfect other areas. So I don't think that intermittent installations really have any role in
Hmm.
treating chronic bacterial cystitis. Sure, people get relief,
Yeah.
but they will fail.
Does that mean you have patients that are doing installations after every void, or is this just theoretical?
No, it is. I have
You do.
I have one going right now that has had
Okay.
21. She's had 21 cases of C. diff,
Wow.
and, and can tolerate, you know, half of a macrobid a day.
Hmm.
Uh, and so we were really left with no other choice.
Hmm.
It's
Yeah,
a
that must
commitment,
be
and
hard to
she's
manage.
doing it.
Okay. How long do you still have to continue that kind of treatment
Absolutely.
for a year as well?
Absolutely. At least whatever it takes.
So why does treatment take that long? Can you explain the theory behind that?
Well, I think that the reason that it takes that long is because the entire urothelial layer, which, 5 to 9 cell layers thick,
Hmm.
has become contaminated,
Hmm.
invaded by the bacteria that have learned to live inside the bladder cell.
Hmm.
They're not necessarily in a biofilm. They're not necessarily floating around in the urine. They are essentially parasites that are living in the bladder cell. And the longer they're there, the deeper they go into the bladder wall.
Hmm.
And if the whole bladder wall thickness is involved, I I, I feel like it's about a year, for that bladder wall to completely reestablish itself with cells that are not infected. It's it's
Yeah.
it's quite a journey.
Yeah, that's a long time. You mentioned two patients that just don't get better. Is there any escalation of treatment that you take at a certain point for people that don't seem to be improving?
Yes, I mean, if I have a patient that is not making any progress, we can't identify anything on uh, culture or DNA. So we really are not making any progress. You know, I'll actually go to IVs. Do whatever we have to do to to get better coverage and see if they will respond. And there are a very, very small group of patients that are not going to respond.
Hmm.
And I don't know the answer to that. I don't know why that is. Um, and then if that's the case, then we do whatever we can do to manage their symptoms the best. I'm not an advocate of bladder removal or anything like
Hmm.
that for this condition.
And you mentioned IV treatment. Is that something that you can do long term, or is that usually shorter periods of time?
It's going to be long term. If they have the condition is treated the same, whether it's oral IV. The
Okay.
bacteria have to be managed the same. You can't fix this problem with a short course of anything.
Hmm. With IV treatment, does that mean a daily administering of that, or is that more
Yes.
intermittent? Okay.
No, they would have a PICC line or a port placed,
Okay.
and commonly the medication that we use for that is daily, and they would administer it themselves daily.
Which is another highly managed thing, I guess, like the installations puts a lot of onus
Yes,
on the patient.
it does.
How do they manage that usually?
I find that the vast majority of them manage it very well. It's actually they've made this such a simple thing here in the U.S. that it's they get their PICC line placed, they're instructed on how to do it.
Hmm.
The medication shows up every 3 or 4 days in the mail. They put it in the refrigerator and administer it. No problem.
Okay. Yeah, I haven't spoken to anyone that's on that kind of treatment, so I am interested in that. What kind of percentage of your patients do you think end up with that kind of treatment approach?
Less than 1%
Okay,
by
so
far.